Absolutely. And I feel like you've been leading a bit of the charge here. And I saw one of your recent tweets, one of our ways to reduce the burden of therapy, you're saying, is hypofractionation. We used to talk a lot about brachytherapy as a radiation sort of technology that would allow us to have fewer treatments. Where do you see, brachytherapy evolving as we shift towards this SBRT-based external beam landscape?
So let's differentiate or talk about intermediate risk first, and then we'll talk about high risk. And there's a nice segue into this trial that we're running right now. Intermediate risk patients, brachy is still considered the king. If you look at the CCO ASCO guideline that I was part of a couple of years ago, I think it was published in JCO in 2017, suggested, there were 3 randomized control trials suggesting that brachytherapy boost was better than external beam alone. But most of those patients were in the high-risk population. So let's talk about that for a second. So in the intermediates, I think we feel like SBRT brachytherapy boost. So it's typically one brachytherapy implant using low-dose rate brachytherapy, or there's a slightly newer technology called high-dose rate brachytherapy. And that's usually paired with 3 weeks of external beam radiotherapy. And we believe we've looked at different cohort studies that have prospectively collected data on these patients. And basically the patients are the treatment is tolerated the same, and their oncologic outcomes are the same. So if you have a choice of 5 treatments of external beam radiotherapy, which doesn't require an anesthetic, or 15 external treatments with 1 brachytherapy implant, you're probably going to take 5.